Because of recognized deficiencies in the reporting and conduct of randomized controlled trials, the consort statement was created with the direct aim of improving the reporting of RCTs in the human health literature. This was followed by several published modifications to the consort to address specific needs, including the reflex statement, reporting guidelines for randomized controlled trials in livestock and food safety, which addresses characteristics of livestock and food safety randomized controlled trials. While the consort and reflex statements were designed to address issues related to the conduct and reporting of randomized controlled trials, many epidemiologists, researchers, and clinicians recognized the need to address deficiencies in the conduct and reporting of observational studies as well. Observational study designs also have design and conduct features that are critical in order to draw valid conclusions about the internal and external validity of the study. In fact, compared to randomized controlled trials, observational studies run a much higher risk of selection and assessment bias. And even though authors reporting observational studies should be aware of the limitations of these types of studies, they often fail to report appropriate methods to control for selection and assessment bias. In a 2004 review published in the British Medical Journal, 73 observational studies, mostly cohort and case control studies, were examined to determine the rigor with which they appropriately reported their experimental design. The authors found that the exposures being evaluated in the studies were usually quantitative in nature, but they were collapsed into ordered categories without describing for the reader how the category limits were determined. They also found that sample selection, the number and characteristics of potential subjects who refused to participate, and methods to ensure data quality were insufficiently reported. In addition, few articles explained how they chose variables to evaluate or control for confounding. And even though many articles performed subgroup analyses, actual tests for interaction were rare. A common concern with observational studies is when multiple associations are tested without prior prioritization as a primary hypothesis, generally increasing the risk of type 1 errors, of false positive claims. The authors also found evidence of publication bias in the topics addressed by the observational studies evaluated. While there is documented concern about the quality of observational studies for human health questions, is there any evidence that observational veterinary studies are superior? A study done by Jan Sargent to evaluate the quality of reporting for food safety observational studies found that there were important deficiencies in many of the studies published in peer-reviewed journals. These included poor reporting of methods to control confounding, nearly half did not assess model fit, or provide a rationale performing subset analysis, and more than 1 in 4 did not describe how they controlled for non-independence of study subjects or why outcomes were aggregated to a higher level of allocation than the level measured. Observational studies such as cohort, case control, and cross-sectional studies are often written in ways that do not clearly inform the reader how the study was designed and conducted. Following the example of the consort statement, the STROBE statement, Strengthening the Reporting of Observational Studies in Epidemiology, was published in 2008. Similar to the initial publication of the consort statement, the STROBE statement was simultaneously published in several distinguished journals, including the Annals of Internal Medicine, the British Medical Journal, the Bulletin of the World Health Organization, the Lancet, Preventive Medicine, and others. This slide depicts the STROBE statement as published in the Journal of Clinical Epidemiology. The STROBE checklist is similar to that found with the consort statement, with appropriate differences because of the characteristics of observational studies. There are 22 sections or topics that should be addressed by each publication, with recommendations to the authors to enhance clear communication. These recommendations, when followed, allow the research consumer to quickly determine the ability of the study to control bias and confounding, and to determine if the study has application to his or her particular clinical question. The following slides report the 22-item checklist of the STROBE statement. The first item in the STROBE checklist is a recognition that the title should clearly indicate the study's design, that is, prospective cohort, case control, or cross-sectional. The abstract should include a clear description of what was done and what was found. This includes a description of the specific study populations, an explanation of the measurements used, such as risk ratio, odds ratio, or life table, and the results. Limitations and potential uncontrolled sources of bias or confounding should be discussed. The introduction should provide the scientific background and explanation of the rationale for the study. This should include a description of the nature, scope, and extent or magnitude of the problem under study, and the pathophysiologic basis for the proposed comparison groups, either based on risk factors, prognostic factors, diagnostic test results, or therapy. It should also identify gaps in current knowledge that are addressed by the study. For item 3, the author should clearly state the objectives that were introduced in the scientific background and explanation of rationale section. A well-written objective will specify populations, exposures, and outcomes, and parameters that will be estimated. If important subgroup or additional analyses are added after the study data has been collected, that is, not during the planning phase, these additional analyses should be clearly differentiated from the original study objective. The methods section should describe what was planned and what was actually done in sufficient detail to allow others to evaluate whether adequate controls for bias and confounding were designed into the study to result in reliable answers, and to assess whether any deviations from the original plan were reasonable. Key elements of the study design should be described very early in the methods section. For example, authors should indicate that the study was a cohort study, which followed people over a particular time period, and describe the group of persons that comprised the cohort and their exposure status. Similarly, if the investigation used a case control design, the cases and controls and their source populations should be described. If the study was a cross-sectional survey, the population and the point in time at which the cross-section was taken should be mentioned. The setting, location, and study dates may affect the external validity of the study. It may be relevant to report the geographic location where the trial was conducted, the population recruited for the study, the starting and ending dates of subject enrollment, exposure and disease occurrence, and the date follow-up ended. Detailed descriptions of the criteria used to establish eligibility of study subjects should be clearly stated. Investigators commonly restrict a study population by defining clinical, demographic, and other characteristics of eligible participants. Typical eligibility criteria relate to age, sex, diagnosis, and comorbid conditions. Authors should also report the larger group from which the study population was selected, such as all driver's license holders in the state of Kansas, or all patients in a particular hospital database admitted over a certain 2-year period. The outcomes, exposures, predictors, risk factors, potential confounders, and effect modifiers should be clearly defined, and they should be directly linked to the objectives and hypotheses. The methods used to measure each variable and outcome should be described. If possible, the case definition used by all data contributors should be provided, and the training of the person or people responsible for assigning that diagnosis should be described. If specific diagnostic tests contribute to the assessment of the outcome or risk groups, include the sensitivity and specificity estimates of the tests. Selection bias, information bias, and confounding are significant concerns in observational study designs. If the relationship between exposures and the outcome is different between cases and controls, the estimate of that relationship will be distorted. By excluding animals that don't have the exposure of interest in cohort studies, and those that don't have the outcome of interest in case control studies, observational study designs are inherently at risk of creating selection bias. Selection bias can be minimized by random selection from the pool of subjects that meet the inclusion criteria, but it cannot be completely eliminated. Once a study is started, it is impossible to correct for substantial selection bias, and if such a study is published, the results must be ignored. Information bias occurs when measurements of exposures, outcomes, or confounding factors are misclassified using case definitions or diagnostic tests that are inaccurate or unvalidated. Surveys of animal owners or caretakers are subject to recall and reporting bias. In addition, differences in surveillance intensity, length of follow-up, or likelihood of loss to follow-up between exposed and non-exposed, or cases and non-cases, will introduce information bias. Information bias is controlled by blinding in randomized controlled trials, but because blinding is not possible in observational studies, this type of bias is a great concern. Because these sources of bias are nearly impossible to eliminate from observational studies, efforts to reduce them must be described in the methods section of the report. Failure to report how sources of bias were controlled calls the validity of conclusions from the study into question. Use of adequate sample size to detect treatment differences that are economically and biologically important is fundamental to sound trial design. A study should be large enough to obtain a point estimate with a sufficiently narrow confidence interval to address the null hypothesis and primary outcome identified in Item 3. Although the information needed to make precise sample size calculations for observational studies is often unavailable or can only be roughly estimated, authors should report how sample size was determined. Quantitative data about exposures, effect modifiers, confounders, and outcomes are often grouped to create a categorical variable. Grouping choices can have an extremely important impact on the data analysis. The authors should clearly describe the grouped quantitative data, including the number of categories, the cut points, and the category mean or median values. Investigators may choose cut points for groupings based on commonly used values that are relevant for diagnosis or prognosis, for practical or convenience reasons, or on statistical grounds. They may choose equal numbers of individuals in each group using quantiles, or the investigators may believe that they will gain more insight into the association with the outcome by choosing more extreme outer groups and having the middle group or groups larger than the outer groups. Readers should be informed if cut points are selected post hoc from several alternatives. If quantitative data is modeled as a continuous variable, it is important to not assume the relationship between the exposure and outcome is linear. Authors should report the alternate models that were tested, such as log transformed, quadratic, or cubic relationships. The statistical methods used to analyze the data should be clearly stated. The statistical analysis for the study's primary hypothesis should be determined before the study is begun. If additional analyses are done after initial evaluation of the data, this should be explicitly communicated to the reader. If model comparisons are made to narrow down a list of potential confounders for inclusion in the final model, this process should be described. Whether subgroups of the study population should be analyzed is open to debate. If it is done, readers need to know which subgroup analyses were planned in advance and which were initiated only after data inspection. Missing data are common in observational research studies, and a clear description of how they were handled is necessary. For example, the author may write, "We accounted for missing data by using missing at random assumptions," or "We restricted analysis to subjects with complete data." Cohort studies are likely to suffer from loss to follow-up. If loss to follow-up occurs more commonly in exposed or unexposed animals, or in animals that develop particularly severe or mild disease, the study will have information bias. Authors should report how many subjects were lost to follow-up and what censoring strategies were used. Finding appropriate controls for case control studies is frequently difficult. Authors reporting individually matched case control studies should clearly indicate what criteria were used to match controls to cases. Cross-sectional studies often have complex sampling strategies based on several layers of clustering, such as state, farm, pen, litter, etc. These strategies should be clearly explained to the reader. And finally, sensitivity analyses to compare the results obtained from the study to alternate methods of analysis or assumptions are often used to clarify the level of a potential confounder necessary to change the final direction of the study results. The results section should provide a clear and factual account of what was found in the study. The number of study participants should be reported at each stage of the study, including determining the number eligible for the study, the number at each stage of recruitment, the number that complete the study, and the number used in the analyses, and reasons for non-participation or loss at each step. Authors are strongly encouraged to include a flow chart to inform the reader the level of participation and response or follow-up percentages. For case control studies, the flow of participants should be described separately for cases and controls. The first table in most studies should be a description of the studied participants. This is likely to include important characteristics such as age, breed, weight, and sex reported for each group in the study. Continuous variables should be summarized using the mean and standard deviation if the data has a symmetrical distribution, or using the median and an appropriate percentile range if the data has an asymmetric distribution. If these characteristics vary widely between exposed and unexposed animals for cohort studies, or between cases and controls for case control studies, the results of the study are highly questionable. In addition, by providing descriptions of study participants, the reader can judge the generalizability of the findings to their specific clinical questions. Another table that should be included in the results section is one that indicates the number of animals with missing or censored data for each outcome measured. For cohort studies, the average and total amount of follow-up time for exposed and unexposed populations should be presented. This information is interpreted in the same way as the study participation descriptors. If these characteristics are widely different between exposed and unexposed, or cases and controls, the results of the study are not reliable. Either in a table separate from statistical evaluation of associations, or sometimes in the same table, the number or percentages of animal in each outcome for cohort studies, exposure category for case control studies, or exposure and outcome categories for cross-sectional studies should be clearly reported. Whether or not they are included in the same table as the outcome data, the measures of association should be presented with both the estimates before any adjustments are made for potential confounders and after being adjusted for confounders. This allows the reader to evaluate the effect of the confounder. The authors should explain all the potential confounders that were considered and the criteria used to include or exclude them in the final statistical model. The inclusion and exclusion criteria should be based on knowledge of or explicit assumptions about causal relations. If a backward deletion or forward inclusion strategy was used to select confounders, explain the process and give the significance level for rejecting the null hypothesis of no confounding. It is important to recognize that if continuous variables are categorized, the selection of category boundaries can have important impacts on the analysis. Sometimes clinically relevant cut points can be used, and in other situations, quantile-derived categories are more appropriate. Regardless of how the category boundaries are chosen, the range of data within a category, as well as the mean or median values within the category, should be clearly communicated. Observational studies are designed to test associations between an exposure and a disease outcome, and the results are reported in relative terms, such as rate ratios, risk ratios, or odds ratios. This is appropriate for statistical evaluation of the strength of association, but may not always provide the most meaningful clinical information. In many studies, authors should provide clinically meaningful measures such as absolute risk reduction. In addition to analysis of the primary hypothesis, it is common for other analyses to be conducted with data from observational studies. These additional analyses may address specific subgroups, potential interactions between risk factors, or alternate cut points or definitions of study variables by the use of sensitivity analysis. If the overall results or analysis of the primary hypothesis reveals little or no effect, there is great danger of finding statistically significant associations due to chance alone when fishing for evidence of subgroup-specific associations or effect modifications, also known as interactions. This does not mean that one shouldn't investigate whether overall associations are consistent across subgroups, preferably subgroups identified prior to initial data analysis, particularly if the study is large enough to have sufficient data in each subgroup for a high-powered analysis. If interesting interactions or subgroups are only identified during data analysis versus as the result of an a priori objective, whether or not they should be reported is debatable. It is possible that these may be important findings. It is also possible that they arose due to small sample size, bias, confounding, or chance, and that they will not stand the test of time. Regardless of whether or not an investigator chooses to report the findings of these fishing expeditions, reporting which analyses were planned and which were not will allow readers to judge the findings' implications. Sensitivity analyses are helpful to investigate the influence of choices made in category boundaries, cutoff values, and choices in the statistical analysis. If many sensitivity analyses were performed, it may be impractical to present detailed information for all of them. It may be sufficient to report that sensitivity analyses were performed and that they were consistent with the main results presented. If concerns about the main results are identified, a detailed presentation of the sensitivity analysis should be included. The discussion section should address the issues of internal validity and applicability of study findings to other populations, as well as to provide a summary of key findings without extrapolating beyond the limits of the study data. By carefully structuring the discussion section to address the original objectives and hypotheses with the data generated by the study, authors can avoid speculation and overinterpretation of the results, while at the same time helping the reader to grasp the implications of the paper. The STROBE statement recommends that authors structure the discussion by presenting the following. First, a brief synopsis of the key findings, including a presentation of possible mechanisms and comparisons of the results with relevant findings from other published studies. Second, a discussion of the limitations of the studies. This is important not only to identify sources of bias and confounding that could have affected the results, but also to discuss the relative importance of different biases. The authors should also discuss any imprecision of the results due to study size and the precision of measurements for exposures, confounders, and outcomes. When discussing limitations, the authors should compare the study with other pertinent literature in terms of validity, generalizability, and precision. Third, a brief section that summarizes the implications of the study for clinical practice and research. Overinterpretation and speculating beyond the limits of the study data is common and seems to be inherent in human nature. When interpreting results, authors should consider where the study fell in the continuum between discovery to verification, and potential for bias, including selection bias, information bias, and loss to follow-up. Due consideration should be given to confounding, the results of sensitivity analyses, and likelihood of chance findings due to extensive subgroup or interaction analyses. A review of the existing published evidence from different types of trials should always be included in the discussion, and authors should put their results in context with similar studies and explain how the new study affects the existing body of evidence, ideally by referring to a systematic review. Finally, generalizability, also called external validity or applicability, is the extent to which the results of a study can be applied to other circumstances. Generalizability is often a matter of judgment that depends on study setting, the characteristics of the study animals, the exposures examined, and the outcomes assessed. Thus, it is critical that authors provide readers with adequate information about the setting and location, eligibility criteria, the exposures and how they were measured, the definition of outcomes, and the length of recruitment and follow-up. Knowledge of the absolute risk or prevalence of the exposures, which often vary across populations, are helpful when applying results to other settings and populations. The last item on the STROBE checklist is a recommendation to disclose the presence or absence of financial and other conflicts of interest. This requirement by some journals arises from studies that show strong associations between source of funding and the conclusions of research articles. These associations are reported not only for studies funded by for-profit organizations, but also for studies sponsored by government and nonprofit organizations. Authors or study funders may have conflicts of interest that influence study design, choice of exposure, outcomes, statistical methods, and selective publication of outcomes or whole studies. Therefore, the role of funding sources should be described in detail, including what parts of the study for which they took direct responsibility, such as study design, data collection, analysis, drafting of the manuscript, and decision to publish. Other sources of undue influence include employers, for example, university administrators and government supervisors, advisory committees, litigants, and special interest groups. The STROBE statement was developed to provide recommendations for reporting observational studies. Good reporting reveals the strengths and weaknesses of a study and facilitates sound interpretation and application of study results. The STROBE statement also can be used to improve the planning and design of observational studies and as a guide for peer reviewers and editors in their evaluation of manuscripts. In addition to the STROBE statement itself, an explanation and elaboration document from Vanderbroek et al. Has been published which provides helpful guidance for authors and readers alike and was used extensively in the creation of the preceding slides. I have introduced the concern that observational studies are often reported and/or conducted in ways that leave the research consumer uncertain as to the validity of the studies or convinced that the studies, and hence their findings, are seriously flawed. Another method to report research trial findings is through systematic reviews or meta-analyses. These types of reports are considered to provide the highest level of evidence for making clinical decisions. Surely authors of these types of studies that evaluate the quality of other research publications carefully follow procedures that reduce bias and confounding when evaluating the questions they study. To address this question, a study designed to evaluate the quality of meta-analyses was performed. This study specifically looked at study design, appropriateness of inclusion criteria for articles, control for bias, appropriate statistical analysis, sensitivity analysis, and interpretation of the results for meta-analyses. Of the 23 specific items evaluated in each meta-analysis, the mean number appropriately addressed was about 12, or 1/2. While this level of appropriate reporting was improved compared to earlier studies by the same authors, the quality of systematic reviews and meta-analyses is not as high as it needs to be for confident use by clinicians and other research consumers. Following the consort and STROBE statements, an effort was initiated to publish the preferred reporting items for systematic reviews and meta-analyses, or PRISMA. This guideline was published in 2009 and provides guidance to authors writing systematic reviews and meta-analyses. As with the consort and STROBE statement, the PRISMA provides a checklist that allows readers to efficiently evaluate study quality. And as with other statements, PRISMA also provides a template to authors to ensure that they can design well-controlled studies and write clearly so that research consumers can appropriately integrate a particular study's findings with other evidence. Because of the expanding number of reporting guidelines that have been and are being developed, the online Equator Network was launched to provide a single site with most of the available research study reporting guidelines, as well as other resources for scientific authors, reviewers, and editors. This site provides access to reporting guidelines for many different study types, including experimental, observational, agreement, and economic studies. The overarching goal is to promote transparent and accurate reporting of research studies, as well as to provide resources to enhance the readability of scientific writing. The final effort to improve study reporting and to assist research consumers to appropriately interpret the body of evidence for a particular clinical question is the campaign to register trials at their onset. The theory behind trial registries is that publication bias is a significant concern in the health sciences, and this type of bias cannot be detected by even a careful consumer using tools such as Consort, STROBE, and PRISMA. There is evidence that studies with positive results, that is, that refute the null hypothesis, are published at a greater frequency than studies with neutral or negative findings. This can occur when research sponsors run several studies, often with low power or designs that are prone to bias, and then only publish the ones that demonstrate the most favorable results. This is a specific concern for observational studies using large databases in that researchers may perform many analyses, also called fishing or dredging, and only report those that are statistically significant or provocative, and not to report all the analyses that failed to provide evidence to refute the null hypothesis. Unless an author specifically indicates all the associations that were tested, there is no method for a consumer reading an observational study to determine if the results reported were from a hypothesis established prior to the initiation of the study, or simply a chance finding because multiple associations were tested. Even as a trained and careful research consumer, very few publications would allow one to know the number of analyses performed or to know if the original hypothesis and statistical methods were altered after the study began. The establishment of trial registries is intended to aid research consumers by registering all studies at the time they are proposed or funded. The registry would require that researchers document the hypothesis and protocols for the trial before the study is initiated, and then the author would have to inform the registry if the study was ever published, and if so, in what journal or format. Trial registries would allow one to compare the final report with the study that was originally proposed, which provides information about whether or not the initial hypothesis was addressed in the final publication, if the number or type of study subjects was meaningfully changed, if study particulars, such as how subjects were allocated to treatment or method of blinding, were altered once the trial was underway, or if conclusions are made that were associated with the original hypothesis. In addition, for any particular clinical question, one can find all the studies that were proposed to address it and then compare the number and types of studies that are ultimately published to the number and types of studies that are not published as an important factor in assessing the possibility that studies finding neutral or negative findings have been lost due to publication bias. This information is currently rare, but research consumers would be able to make much better judgments if it were widely available. Trial registries are gaining recognition and, of course, pushback, and because of the potential to improve transparency and overall quality of research, I expect the requirement to register all or most research studies at the time they are funded to become increasingly common. All types of studies, including observational studies and systematic reviews, are only valuable for increasing our understanding of the natural world when they are designed and conducted with strict adherence to methods to control bias and confounding. When authors fail to adequately communicate whether or not or how they controlled for bias and confounding, research consumers are not able to evaluate the validity of research findings. The STROBE and PRISMA statements provide structured methods of evaluation for research publications, and the increased use of trial registries provides a transparent method to detect risk of publication bias or type 1 error from multiple assessments of the same database. In addition to the benefits these efforts provide to research consumers, they also provide valuable guidelines for the proper design, conduct, and reporting of research studies for both the novice and experienced researcher.